Perfect. Yes, I see so many people have already joined in. Okay. Hello, everyone. Good morning, good afternoon. So nice to see all of you here. My name is Erta Kalanxhi, and I'm a research fellow and director of partnerships at One Health Trust. It's my great pleasure to moderate this webinar today. So thank you very much for joining. I know this is a very busy week for many events, but especially for the World AMR Awareness Week events. So amongst all these other things that are happening, thank you very much for taking the time to join this very important discussion. So we will have a discussion. We will talk about vaccines and how they can be integrated in AMR strategies. We'll talk about different topics related to AMR and vaccines. And we will make sure to leave a few minutes at the end of this hour for questions from you. So please take the time to enter questions in the Q&A box, and also keep an eye for the chat box, because we'll be sharing links to some of the documents that we will be mentioning or discussing during the talk. So it's been a very big year for AMR. A lot of work has been going on towards the political declaration that was approved at the end of December. I would say a decade of work was dedicated to making sure that the second declaration had measurable targets and objectives for AMR. So while some objectives are there, I believe that the declaration provides the base, an opportunity to develop additional targets and additional objectives that can be monitored, that can be evaluated, and that can be adopted in country-specific context. So it's my pleasure today to talk about prevention. Prevention is a very important aspect of the AMR story. There's been a lot of data accumulating, quantifying the impact of preventive interventions, such as access to improved water hygiene and sanitation, infection prevention control, and last but not least, vaccines. So earlier this spring, the Lancet series on AMR came out with a series of papers that talked about AMR burden. At the same time, it really provided a highlight or overview of the impact that preventive interventions can have on AMR. So with regards to vaccines, improved access to current existing vaccines or routine pediatric vaccines could avert 180,000 deaths per year. And this is without considering the impact of vaccines in development or those that can be targeting different age groups. So the data and the evidence is there. It has been increasing a lot in recent years. The WHO has also done a lot of work to solidify the position that vaccines have in AMR mitigation. Their most recent report came out talking about the impact that vaccines can have on 40 different pathogens. We will provide the links for these documents in the chat as well. But basically, the global perspective, it's promising, and it really outlines the importance of vaccination in not only reducing the infectious disease burden, but also reducing the need for antibiotics, or antimicrobials in general, two very important drivers for AMR. So at One Health Trust, we've been working a lot in coming up with some of this evidence, but also in initiating conversations between immunization and AMR departments. And we've been doing this through the Global Antibiotic Resistance Partnership, which is a network of experts in across countries in Africa and Asia, where we present and discuss evidence that connects vaccination with AMR mitigation in an effort to improve the collaboration between these two groups and sort of bring more country-specific or country-relevant evidence that can help inform policy. I'm very happy to say that today we have experts who are also members of GARB groups from Bangladesh, Nepal, and South Africa. And we are also joined here by our dear WHO colleague, Anand, with whom we work very closely in AMR national strategy evaluation projects. And so we are very, very happy to be here and talk about vaccines in AMR strategies from a country-specific context. Because while the global perspective is really good and really supportive of including vaccines in a more meaningful and impactful way in AMR strategies, there's still a long way to take these recommendations into policies that are relevant and can help inform decisions at the country level. So I will not take much longer. I'm going to start our discussion today by inviting our first speaker, Dr. Wasif Khan, who is a scientist at the Infectious Disease Division at ICDDR in Bangladesh. Dr. Khan is going to talk about the impact of vaccines in Bangladesh and how they're integrated in the national policies in the country. So, Dr. Khan, thank you so much for joining us today, and over to you. I know you have a few slides that you're going to share with us. I'll ask for those slides to come up. Thank you very much.
Sure, thank you. Can you have, okay, great. Thank you, Dr. Erta, for for a nice introduction of today's webinar and giving me an opportunity to be a panelist. Can I have the next slide, please? So before I talk about Bangladesh infectious disease burden, just to give you a demography, if people who have no idea about Bangladesh, it is a country of over 180 million population, almost half of United States of America, but by size, it is equal to a state of Wisconsin. So it is a densely populated country where we have an extreme high burden of infectious disease. And on the left table, you can see the most common disease, infection-related respiratory TB is the number one, followed by enteric, other infectious neglected tropical disease, and HIV. The top causes pathogen that cause infectious disease includes the Mycobacterium tuberculosis, strep pneumoniae, respiratory syncytial virus, Salmonella typhimurium, and rotavirus. And you know that all this has got, this bacteria and viruses has got vaccines, but other than strep pneumonia in Bangladesh, no other vaccines has yet been incorporated in the national program. On the right, the slide shows the Fleming Fund studies that is going on in different countries in Asia. This Captura Consortium, which started from 2016, the report of 2022. So they basically collect the pathogens from the lab in 34 labs and looking at the multi-drug resistance. And the top one is Escherichia coli, followed by Staphylococcus aureus. And the alarming situation is that over 50% have the multi-drug resistance. So it's definitely a big issue here. Can I have the next slide? So in Bangladesh, the immunization program actually launched in 1979 with 6 vaccines. And by now in 2024, we have 11 vaccines that is given free of cost by the government. The most recent was human papilloma virus that was included in last October 2023. So the next one, please. So this national immunization has definitely had a big impact, and there are a number of achievements. If I highlight a few of those, from 2008 onwards, we have achieved the maternal and neonatal tetanus eliminated, which is still status is maintained, and the country is polio-free since 2014, and also Bangladesh achieved the rubella and congenital rubella syndrome control. There has been a lot of impacts also been shown by adding this. One of those, a few of those that I've highlighted below are reduced in the under 5 death from 133 to 27 per 1,000 live births from 1993 to 2021. Measles incidence case has reduced from nearly about from 15,000 to less than 1,000. And the national introduction of pneumococcal conjugate vaccine has really shown nearly about 50% reduction in the strep pneumonia cases. Next one. Next slide. So this slide basically shows if we can add more vaccines in the immunization program, there will have a direct, we can avoid antimicrobial use, misuse, and also that can reduce the AMR. For example, the PCV has already been introduced in children, but it's not been given to the risk populated adults. So this could be considered. And then rotavirus, then typhoid conjugate vaccines are not been introduced yet, although there have been several studies done from Bangladesh and clearly shown that has got a big impact in reducing misuse of antibiotics as well as multi-drug resistance can be reduced. And similarly, the tuberculosis is a big issue. The routine post-exposure TB vaccine can also reduce 50% efficacy against symptomatic disease and can avoid 22% of rifampicin-resistant TB cases and 8.4% of rifampicin-resistant TB deaths from Bangladesh. A report came between 2020 to 20. It is a prediction that it will be from 2020 to 2035. So definitely the vaccines has a big role. Next slide, please. However, the major concern with the problem is that immunization is not yet been adequately included in the AMR strategy in the country. We know that the 5 objectives of AMR Global Action Plan of this, the National Action Plan of Bangladesh just is focusing on surveillance, infection prevention control, and antimicrobial stewardship to make the antimicrobial containment journey cost effective, but they are not addressing much on the investment that includes medicine, diagnosis, and primarily the vaccines. Even in the recent National Strategic Plan of 2020-25, they didn't mention anything on the vaccine use, so which is an important lacking, I would say, from the government perspective. Next slide. Next slide, please. So to mitigate AMR with vaccine, we need to expand use of licensed vaccine to maximize impact of AMR. For example, as I mentioned earlier, production of rotavirus, typhoid, TB vaccine. And the more concern for Bangladesh is we don't have much time. By 2029, the Gavi support is going to be a transition out. So the country must start to think from increasing domestic vaccine production in the future or to explore investment sources. And as Dr. Karta at her beginning, she mentioned about we have to ensure and maintain the universal uptake of childhood vaccines. And there has been survey done from Bangladesh, which has shown that the full vaccination coverage by age of 12 months is still around 80%, whereas the SDG goal is it has to be 95%. The missed communities have been constantly linked to stagnant vaccination coverage for the last decade, and there's a high percent of invalid doses. Next slide, please. So basically, there's a lack of update of existing guidelines and developing regulatory and policy mechanism to accelerate approval and use of new vaccines. There's a lack of integration of cross-cutting activities between the National Action Plan and National Immunization Program, which needs to be done. And one of the other important thing, as Dr. Erta, she mentioned at her beginning, that inadequate information, lack of impact studies like health economics of AMR, AMC, which are very important, especially while we talk with the policymakers, because they want to see the figures, the cost, how vaccine can really reduce not only AMR, the total package of reducing the cost in the treatment and everything. And adult immunization is just under discussion. Again, the budget is the main concern, so I don't think the government is thinking right now. And the major issue is about the same thing, the funding gap in Bangladesh and other low and middle income countries to sustain additional funding is needed. And unfortunately, in Bangladesh, the total budget of the yearly budget, 5% is given on the health sector. So more than near about 70% people have to pay from the out of pocket. So these are the major concerns to address these issues of AMR. So I think this was my last slide. Yeah.
Thank you, Dr.
I'm done. Thank you.
Thank you
Thanks.
very much for that. I did notice that you provided some data and you talked about the importance of the rotavirus vaccination. And I bet you have been working a lot with that, but it seemed to be approved since 2018, but is still waiting introduction. Are you aware of how the prioritization is taking place with regards to these vaccines, and why is the rotavirus vaccine not introduced, given its impact that has been shown also globally?
Yeah.
Thank you. Dr. Khan, my
Yes.
question was on whether there was any indication as to why the rotavirus vaccine is not included yet.
Okay. Sorry, I didn't realize. So the
Yeah,
one
no,
of
no.
the reasons actually the budget, because my feeling is the government doesn't the vaccines they are getting from Gavi and other sources, because the local production are there are two pharmaceutical companies that are making vaccines, but it's not adequate enough. And they are more concerned that if they add more vaccines, there will obviously the cost will go up, and unless as the Gavi will be going out soon. So they just want to make sure that those vaccines which are already been given, make sure that this can continue, and unless there's new pharmaceutical who can come up with in the interest of developing vaccines locally. So that's the biggest concern. I feel like the budgetary issues, definitely the government's limited budget on the health sector. And as I said, the impact studies, we need to have more economic impact studies that can convince the policymakers, as you mentioned at the beginning.
Yeah, that the investment is worth making. Okay.
Right.
Thank you very much, Dr.
Thanks.
Khan. I think we will continue this discussion, and we have a lot of opportunities for additional questions, and both from the panelists and also from the audience later on at the end of this hour. Just checking out that we're doing well for time. Yes. Thank you. So I'll move over to Dr. Abhilasha Karkey, who is a previous member of the GARP network in Nepal. Dr. Karkey is director at the Oxford University Clinical Research Unit in Nepal. And we're very happy to have her here today because she has some experience with both AMR and vaccines, has been working in the field for a while. What we wanted to hear from you, Abhilasha, is on how AMR is actually included in vaccine studies. You have previously been working on a vaccine trial for a typhoid vaccine. Typhoid is an excellent example on how AMR develops, but on also how it can be controlled by vaccination. So I'll be very happy to hear any comments that you have on this. Were there any AMR-related outcomes that were investigated in this trial?
Yeah, so unfortunately, no. So not directly.
Okay.
I think at the initial point, everyone was just focused on efficacy, safety, etc. And I think we did come to a point where we were sort of looking at the impact on the pathogen itself, like, does the AMR patterns change? But I think one of the main problems in looking at directly at outcomes is because these studies are long. I mean, for example, for typhoid, we did the study. It's now on the National Immunization Program, but the immunogenicity studies do continue. So we don't know when they might need a booster shot. Are booster shots needed? So to know whether the incidence of typhoid goes down, so that the logic is incidence goes down means you don't use antibiotics as much. I think that takes time. It's, there's a long follow-up, and it's the same for the pathogen itself. It's a long follow-up that you have to do. And especially for typhoid, there's this whole issue of gallbladder carriage. So, how many carriers are there? Is there any way that we can reduce them? Are they reduced with vaccine? So it's quite complex, and I know there was a huge push to try and look for outcomes, and that's continuing now. I mean, the vaccine's already on the immunization program, but to look for AMR-related outcomes, I think it's taking longer, and I think the only reason is because it's just so complex that, you know, you really need to break it down and look at one problem at a time. And then once you do that, you need a longer period of time, and that means more funding. So that just makes it quite complicated. Yeah.
If we were to kind of clarify for those of us who maybe are not familiar with these studies, what timeframes are we talking about? How long would this trial take? How long has it taken, or it's planned to take?
I mean, for example, for the typhoid, excuse me, for the typhoid vaccine that we did, it's about, you know, looking at all the surveillance studies done before and the whole typhoid, and then on the immunization program, we're talking about something like 6-7 years. So we do have incidents of typhoid before, the AMR patterns of strains before, but I think now we need to look at the incidents after, the AMR patterns after, the carriage rates after. So that's where we are now. And I would think that's still another 4 to 5 years. So, you know, whether you could have these 4 to 5 years within the first 6 to 7 years, you could, but I think that, you know, there's no standardized protocols. In countries like Nepal, even microbiology labs are, you know, they're not exactly where you want them to be. So it just takes a lot of time and money. And I think funding is one of the main issues post the complexity. Yeah.
And what about, if I may call them low-hanging fruits, like measuring antibiotic use? Would that be a measure or an outcome that can be easier incorporated in the setting in Nepal?
I mean, I think in countries like Nepal, that might be more difficult. So we've tried to do that, you know, like look at the use of antibiotic for what, but because you can get antibiotics just about everywhere. And, you know, in a study that we did in 2017-18, we had over 800 pharmacies in the Kathmandu Valley itself. That's not even in a whole country. So I think it's very difficult to know where antibiotics go down, or the use of any antibiotics go down or up. So we focused on hospital pharmacies, but that doesn't give you the whole picture. So it's, yeah, I think, you know, just trying to quantify how much of prescription habits change has been a challenge, to be honest.
Yeah. So it is definitely true that certain AMR outcomes may be feasible or not in various settings. That is for sure, and is evident in what you are talking about right now. But if you were to be given, there's nothing you can do about the time frame is there, but if there were no funding limitations, do you see any other barriers that would prevent having more real world AMR data from vaccine studies?
I mean, I wouldn't say barriers, but how I see, like what I feel could be useful was, you know, if we could develop standardized protocols with AMR related outcomes. For example, simple things like AMR strains, you know, if hospitals could do surveillance, or like there are surveillances that happen, but I think there aren't just robust enough surveillance systems. I mean, I think the pathogens are changing faster than our surveillance programs are. So I think, and I'm talking from the context of Nepal, if the surveillance systems could be made more robust, I think that would give you a lot of information even before vaccine trials came in that could be very useful to look at AMR outcomes later on. So, you know, having standardized protocols and just strengthening microbiology labs, I think would also be a huge change that we could do. So I wouldn't call them barriers. I just think we need to come together more and just think about it more in depth. Yeah, it's just a very complex problem. And I think people just, I mean, we already are, but just more talking more, trying to understand more, I think would be helpful.
Thank you very much. The reason why I ask you these questions is because I think you understand the landscape very well. And through the work that we've been doing in the past 2 years with GARP, one of the biggest questions that we have received usually from country experts is on the actual local data, like utilization of data that is already there, or acquiring new data. And so your insights on this are very, very important. So from our experience, we've also noticed that sometimes the data is already there, but it's not easy to analyze because, as you said, there's a lack of sort of standardized methodology that is being applied in different settings. So thanks a lot. We'll come back to you later. I hope that we get some good questions from the audience. I can already see some red buttons over here. So it means that the questions have come in. I don't have time to look at them right now, but for the speakers, for the panelists, make sure to check them and see if maybe there's a question that you'd like to answer later. So I'm going to move on now to Dr. Sipho Dlamini from the University of Cape Town. I'd like to talk to you a little bit about life course vaccination. So we've been talking about vaccines a lot in the context of routine immunization for the pediatric population. There's also a lot of evidence on the impact that vaccines have short-term for control of outbreaks like cholera and typhoid, where these are situations where antibiotic use is rampant. But what about thinking about the long term? Because, traditionally we think about vaccines for the first years of life, and now we understand the impact that vaccination could have also in vulnerable populations. I'm asking specifically because in the last there's been a recent paper that was quantifying the burden, the AMR associated deaths in the older age groups. And it has increased a lot in the last 20 years. Do you have any input on the role that vaccines could play here?
Yeah, no, thank you. And good morning and good afternoon to the people watching and listening. So I think the first thing is that life course vaccination has certainly been identified by WHO as something that contributes to healthy living and or healthy aging. So I think vaccines certainly play a key role in the different stages of one's life. So it's not just about pediatric or EPI programs, but really about all the other stages of life where they play an important role. So I think that's just the first thing to say. I think the second thing to say is that the elderly population globally is expected to double. I think currently there are about 1 billion people who are above the age of 60, and the estimates are that by 2050 that will double to 2.1 billion people. And those people would are going to be vulnerable to, and are currently vulnerable to, vaccine preventable diseases. And that's because a large proportion have at-risk conditions. So, for example, diabetes and other conditions which place them vulnerable. So the data is there that suggests that vaccination is going to play a key role in protecting these individuals, or everybody else who's got risk factors for vaccine preventable infection, and getting them vaccinated is key because it is going to, one, reduce infections, but also reduce the requirement for either antimicrobials or secondary infections if it's a viral infection related to this. And the data suggests that they too are going to benefit from vaccination, and certainly going to benefit from also this issue of antimicrobial resistance. I think, as you said, the data is suggesting that in this particular age group, the elderly, AMR related mortality has almost doubled in the last 20 years. So certainly vaccination is going to be key because, again, in many settings, low and middle income countries, we may not have the antimicrobials to treat some of these infections. So you probably want to prevent these infections and therefore prevent the need for a antimicrobial course of treatment or the need for unnecessary antimicrobial. So yes, AMR and vaccination are interlinked, especially in vulnerable populations who are elderly.
Thank you very much. I wonder what kind of practical steps can one take to make sure that adult vaccination is sort of introduced more broadly and is advocated? Because while we have an issue with access, so having access to vaccines, there may be other issues for accepting vaccines. I will quote a doctor that I was talking to in a GARP Kenya workshop, that it is difficult to sell vaccines to a healthy adult person because, usually prevention is not always prioritized. So, okay, without making this question very convoluted, are there any practical steps that you think that should be taken, for example, in South Africa to really make sure that that this life course vaccination takes off?
Yeah, so I think the practicalities is that there's a whole list of vaccines, for example, in the elderly that we'd like to have: RSV, influenza, pneumococcal, herpes zoster. So I think the practicalities is that you have to look and see what the epidemiology is in your setting. So, for example, influenza is a low-hanging fruit in many countries, and that I think is a first practical step to do. Getting all your adult population groups who are vulnerable to influenza to get the yearly influenza vaccine. I think what is often difficult is how we sell vaccination in either high-risk groups or even groups who perceive themselves to be healthy, and how we make those arguments for why vaccination is important. And I think the linking between AMR and vaccination is important because there's a good link and you can make good policy arguments for it, whether it's cost effective. There's a cost effective argument there. There's a good public health policy there. And then also, for the general population, you may take your influenza vaccine because you're living with an old person at home. So you're living with your grandmother. So it makes sense for you to get vaccinated because you don't want to give grandmother influenza, which might cause her to suffer from mortality or morbidity from that. So I think it's about choosing and being practical about what is important in your country, and then building up for the other vaccines that are important in that group. Of course, I think the main issue is also how do we make vaccines accessible, and I think policymakers and countries need to develop programs where it becomes easy to get vaccinated as well, just like what we've done for childhood vaccination. It just becomes part of routine care. So if you're diabetic, you're going for your diabetic check, and it's just before the winter season, it's part of the checklist. As you're getting your medication for diabetes, somebody has also said, look, you need your influenza vaccine.
Very clear. One last question. What about immunization groups in South Africa? There are many stakeholders and players. Are they aware of AMR? Is AMR in their agenda from your experience?
Yeah, I think if just globally, there's a growing recognition of the synergies between a good vaccination program and the benefits to AMR. I think the pediatric data has certainly shown that. So if you look in the literature, there's good evidence why pneumococcal vaccination has reduced the AMR burden for that in children. There's beginning some literature that's emerging for adults. Even influenza, there is some good evidence to show that by getting influenza vaccination, you're reducing the use of antimicrobials in adults. So there is a beginning to appreciate the evidence that vaccination plays a role in AMR mitigation. What needs to happen really is a expansion of adult immunization generally, and really capturing high-risk population groups and then moving broadly to that. So there's that discussion beginning to happen in South Africa. Our National Immunization Committee is beginning to look at that and choosing a way of starting to implement that in key populations.
Great. That's really great to hear. Thank you very much for clarifying that, because I think that all of these different nuances are play an important role in the access issue, because countries also have to prioritize, and sometimes it is better to make the right decision when you have all the information. And it seems like AMR is a big part of certain vaccines and should play a part in the decision-making process. To my knowledge, there is no standardized way or framework for doing that at the country level. So I think this is one of the issues that that we see, or the question that is often asked is that there is no specific, there are no specific guidelines at the country level for evaluating the importance of certain vaccines. And I think there's a lot of reasons for that, but we can continue the discussion. We're in I think it's a good transition to make to talk to Anand from the WHO. He's leading the National Action Plan Monitoring and Evaluation Unit at the AMR division. And Anand, thank you very much for taking the time to join us today. I wanted to talk to you a bit about national action plans. I think you are the one, you're the expert in here on NAPs on AMR. We've learned a lot from working with in these plans. I was going to ask you specifically about the recently released, I would say, WHO framework, the people-centered approach for national action plans. It's very interesting to listen to hear a bit more about it now that the political declaration is there. It has some recommendations. There are opportunities for countries to review and expand their national action plans, make them better than before. And the people-centered approach seems promising in the sense that it can sort of like bring a novelty to these new plans. So I'd like to hear more from your side, maybe talk a bit about the approach and how vaccines are positioned in there.
Great.
Yeah.
Thank you so much, Erta, and good morning and good afternoon or good evening to people joining in. Thanks for this opportunity. So why did WHO have to develop a people-centered approach? We have been reviewing the performance of the Global Action Plan since 2015. And over, say, maybe 6-7 years of work and looking at the data, we saw that progress is very, very patchy and ad hoc. It's primarily donor-driven initiatives. And predominantly the focus has been on what colloquially we call the drugs and bugs approach, really focusing on surveillance or the antibiotics. And we felt, looking at this, there were two critical issues. One is there was no comprehensive package that countries are adopting in implementing their national action plans. And secondly, for me, as a sociologist by training as well, what is really important is that people were missing in the Global Action Plan. There were, I think, there were mention of patients just twice in the entire document. So when we started looking at the whole AMR program in most countries, we saw that people's barriers and challenges to addressing healthcare was not included at all in the discussions, in the framing of the national action plans. What also became clear is that there were some very clear health system gaps that were not being addressed. AMR cannot be addressed without addressing, critical health system gaps. And so, so we felt we need to reframe this from a drugs and bugs approach to to putting people at the center of addressing AMR. So this approach basically has 4 critical pillars and 2 foundations. The 4 pillars, the first pillar starts with prevention. And here the focus is on immunization, water, sanitation, and hygiene, and infection prevention and control. So we really feel this should be the core pillar of addressing AMR. Prevention should be the first step. In fact, I often wear a badge on my jacket that says prevent AMR, prevention first. And because by addressing the emergence of infections itself, we can really make a dent in the AMR burden. The second pillar that we really focused on, and I think there were questions as well towards this, is access to basic health services, essential public health functions. Do people, if they have infections, do they have access to basic essential public health functions, including that they don't have very high out-of-pocket expenditures, or they have access to primary healthcare clinics, etc. The third critical pillar, and this was again completely missed in the Global Action Plan, is the focus on diagnostics. Okay, do people have access to diagnostics? Either, I think at the primary healthcare level, it might not be feasible, but do they have networks, reference labs that medical professional can send samples to, etc. This will also help then build the capacity for microbiology and lab technicians and supply chains, etc. So this whole element was missed in the Global Action Plan. So we needed to make sure that diagnostics and diagnostic stewardship is a critical third pillar. The fourth pillar is appropriate treatment. Do people have access to the basic antibiotics? Well, there's so much discussion in all these side events and meetings all over the world on new antibiotics and pumping in billions for new antibiotics. The vast majority of the world, people don't have access to the most basic antibiotics and to use them appropriately. They haven't been trained, they don't have the knowledge, or regulations are not being enforced and implemented in most countries. So those are the 4 key pillars: prevention, access to health services, access to diagnosis, access to appropriate treatment. But underpinning that is what our colleague from Nepal also highlighted. We need good surveillance infrastructure. This needs to happen. And the second infrastructure that needs to happen is strong governance within the AMR coordination committee that has financing, that has ability to reach out to other stakeholders, etc. So just to say, immunization is very important. In fact, it's in the first pillar. I would like to make 2 additional points here. One is the Global Action Plan itself included a lot of focus on immunization. In fact, the core indicators for measuring the Global Action Plan included 4 critical antigens. I think it was if I'm not mistaken, pneumococcal vaccines, influenza type B, rotavirus, and one more, measles. So there were 4 critical antigens covered in the Global Action Plan monitoring mechanism to really encourage countries to say, at a minimum, can you track this, the coverage of these 4 antigens, because this will have an impact on antibiotic use in the future. And then there were some additional ones included, like typhoid, vaccines as well. So the Global Action Plan included emphasis on vaccinations, also included emphasis on research and development for vaccines that are more effective, etc. So that's the second point, that we shouldn't forget that we did start off with emphasizing vaccinations, but what we are seeing is that the linkage has not been made effectively. So thanks to the work by the One Health Trust and also my colleagues in WHO, vaccines and immunization teams, I think this linkage is being further developed and highlighted, and the effectiveness of vaccinations to reduce AMR is being, I think the investment case is being made very, very clearly, that investing in certain vaccines will have an impact on reducing AMR. So I just wanted to highlight that. The third point, if I may, is that we have a fantastic opportunity at the moment. The UNGA declaration has been adopted, but also keep in mind the World Health Assembly endorsed a 10-year strategic and operational framework for WHO to address drug-resistant bacterial infections. So anyone in the healthcare sector, this is the roadmap. The UNGA declaration is a political declaration, but from a health professional's perspective, the 10-year strategic and operational priorities adopted by the World Health Assembly is really the roadmap, and that has a clear emphasis on vaccinations as well. And the big opportunity is we have the Global Action Plan is going to be updated by 2026. So the immunization community should really make sure that certain critical elements that you're pushing for is part of the new Global Action Plan. For example, the AMR committees should include maybe a working group on immunization. In many countries, this does not exist. So they can look at data, they can analyze data together, they look at how they can engage. In most national action plans, there is no linkage to the immunization program in the country. So there is an immunization 2030 agenda, that's there at the global level. So the AMR strategy must be linked to these national immunization program as well. And I think there needs to be more linkages also in civil society. Immunization, my previous work experience was in polio eradication. You have a tremendous civil society engagement in immunization. We need them to start talking about the co-benefits of addressing AMR by strengthening immunization. I think the AMR folks are not going to be coming to every single program to say AMR is a problem, do something. But I think other programs should understand the benefits, co-benefits of their own work. They will be addressing AMR if they do their work better, invest in immunization, etc. So those are some 3 high-level points that I wanted to make. Thank you, Erta.
Thank you so much, Anand. I think very, very good points illustrating really some of the things that must be done. I really liked your comment or value your comment, the comment that you said about working groups that sort of are, or they call them technical working groups that that are involved in national action plan implementation. It is true that while there are working groups on IPC, for example, surveillance, awareness, immunization could be one of them, and they're lacking at the moment. So, but it's only through working, I think, and looking at the evidence together that it's possible to really contextualize and understand how these strategies can integrate. Because from like a theoretical perspective, as you said, it makes sense. We should benefit from this sort of mutual interest of addressing AMR and infectious disease. However, it's like working together, and that actually makes or provides the grounds for better collaboration. So that would be a really good way. You have sort of answered partly my next question, because I was going to ask you, you have the global action plan, and then we have the national action plans that each country has adopted. And many of them share similarities and sort of mirror the global action plan. The WHO has played an incredible role in helping shape these national action plans. Is there a way that you can support countries, or other ways, like steps that the WHO can take into helping sort out all the different elements in this picture, and make sure that immunization is included sort of more objectively in the national action plan? You did mention now the working groups, but if you have any other comments, sort of happy to hear your thoughts.
Excellent point. So as a first step here at headquarters, we are working very closely with the immunization program and the team, and we have meetings with them every 2 weeks, cross-cutting groups where they engage, and we have these discussions. But what we want to see at the WHO level is these interactions go down the chain at the regional level and at the country country level. And sadly, in public health, you have these silos, right? Everyone wants to do their work and everyone else is almost seen as a competitor, which is really sad for me. We are all competing for the same lives to be saved, I think.
Yeah.
But this form of competition between the groups is not very helpful. So we are trying to promote better working with the immunization programs at the headquarters and at the other levels, but also as we start looking at updating the global action plan, we will also be updating the monitoring frameworks. We will also be updating what could a new national action plan look like. So there are some core elements of these that can be inserted into the global action plan framework, which will then lead to how national action plans are developed. So, if it's for example, life course vaccinations that was highlighted, that's extremely important, particularly as we see the global population aging in many parts of the world, and AMR burden significantly increasing in those communities. So we need to bring in those elements into the global action plan update as well. So in fact, one of my to-do lists for next week is to start engaging with the aging group to say, okay, how can we start engaging with you now to become part of the global action plan update? What are your critical needs, et cetera? So I would say, use this opportunity of the update of the global action plan to really provide, information and inputs and feedback. There will be global consultations that will include civil society and others as well. And based on that is how national action plans are then going to be further developed. And we will also start looking at other partners like Gavi, for example, to see how they can highlight the value of certain vaccines or vaccinations on the AMR burden. I think the One Health Trust has already done an excellent work in that, but I think we need these global players to also start highlighting these things. Yeah.
Thank you so much, Anand.
And
I
we
think
have in 2029, we have to provide an update to the UN General Assembly on what we have achieved. And hopefully we can show much more closer working relationships between immunization programs and AMR and actual impact of increased coverage and reduced burden.
That's great. Thank you so much. And I think with this last comments, you have addressed some of the questions. There's been a lot of questions here in the chat. I'm going to just go through some of them. One of the questions was on how, how you can, are they plans? I think it says, do you have plans for consulting with governments? And I believe that perhaps that's towards you, Anand, perhaps, but it's not addressed to a specific panelist, but like it basically, the question talks about the need for consulting with governments at the government level in order to get their buy-in, because it says without their engagement, it's hard to execute vaccination programs for people. So government buy-in is definitely,
Yes.
a very important one. And
they will play a very, very critical role in the consultation process. Governments are going to provide feedback on the global action plan updates and the various efforts, and also civil society and academic institutions, etc. Yeah.
Yeah. So one of the questions that was directed to me was explaining the reasons for the lack of clear guidelines on my country, on a country, whether it's the same in other countries, and whether we can use one country's solutions to apply to others. I think that this we sort of have discussed. Now we are improving the guidelines. The Global Action Plan will be updated. The evidence that is accumulating is out there, and organizations like One Health Trust and a lot of organizations in the space are working to bring this evidence forward to the countries. But again, in my opinion, one of the one of the reasons for the lack is because previously so much effort has gone into trying to understand the AMR burden that, there hasn't been a lot of effort or a lot of opportunities to really focus on the impact that prevention has. And as we have talked about it during the meeting today, the data, what we know now is a lot more than what we knew a decade ago. So now it's up to us to bring this evidence and communicate it in a way that it's understandable and can influence policy in the various countries. So I think that there are many issues, but obviously we're positive about the future. We think that there is an opportunity for change, and just the conversation we have today, it's excellent. You all come from different aspects, you bring different experience, and your expertise is sort of in the different nuances of AMR. So I'm very glad we've come here together to discuss this topic today. I am aware of the time. We're approaching the end. I see that a lot of the questions that are here have sort of gotten the answers during our discussion. However, we will follow up with you over email. We have your email over here. So if there is any specific question that we feel was not answered, we are going to follow up in the chat. So I would like to ask maybe the panelists if anybody has any closing remarks or any comments before we say goodbye for today. Just leave the floor open. I'd like to thank you first for taking your time, because it's a very busy week in many regards. So very happy to see this engagement and very active comments over here.
If I may, Erta, I think we should not forget, I think one of the comments in the chat, the social determinants of AMR. It's very important. And I think we can't just keep focusing on the pathogens and the drugs. There are so many other drivers that lead to people, initially becoming infected with various infections. And those drivers, whether it's based on equity or gender, etc., these social determinants play a very big role. And we are just beginning to understand that from the AMR perspective. But looking in the future, I think focusing on the aspect of prevention, these drivers, these social determinants should be considered in any new plan. Over.
Fantastic. Sipho, over to you.
Yeah, no, thank you, Erta. And I think there have been very good questions. And I just want to emphasize that life course vaccination is, again, an important aspect in trying to mitigate against AMR. And I think, just like Anand said, again, life course vaccination is one of where social justice or social equity in societies can be achieved. And I think this is important in low and middle income countries where healthcare infrastructure may not be great. So, poor access to diagnostics, poor access to treatments, but if you get vaccinated, you may not need diagnostics, you may not need treatment. So just something to think about, and reducing sort of the economic costs related to with illness if you get vaccinated. Thank you.
Yes, a really great connection over here, because as a closing argument, I would say that, or comment, equity, and thank you, Anand, for bringing this up, and Sipho for really illustrating the issue. Equity is a big element that we cannot underestimate, especially since, in fact, through data and literature and data that it's available and very easily to track online, shows that where the AMR burden is greatest, you also have the biggest vaccination gaps. So even though, I will stay away from making a causal relationship or inferring anything over here, but I'd like to say that the impact of vaccination, diagnostics, and access to antimicrobials that are not even, second or third generation can make a huge impact in the areas that have the highest burden. And that's why we're here trying to sort of really contextualize and bring forth this focus on prevention and make sure that, you know, we bring awareness to the fact that even though it's well understood, there are no specific frameworks or guidelines. There's not a lot of data at the country level to really bring these elements together. And we'd like to see more effort into, if, you know, organizing a sort of putting this story, making the story a little bit more understandable and reachable at all levels. And this was a very good transition to not only say thank you and have a great rest of the week, but also to the promise for our next webinars that are going to definitely focus on the social determinants of AMR, including gender, migration, climate, etc. So we look forward to engaging with you again, and we'll see you again. Thank you very much, and have a good rest of the week. Thanks, everybody. Bye-bye.
Bye.